Let's dive straight into this rapid review explainer covering high-yield clinical vignettes for your trauma exams.
Question 40. We've got a 34-year-old female presenting with a stab wound right in the right hypochondrium. She actually has an omental protrusion, but she's vitally stable. So what's the next best step? Is it A, CT scan with contrast, B, observation, C, laparoscopy, D, surgical exploration, or E, manual reduction? The correct answer here is C, laparoscopy. Even if the patient looks completely stable, an isolated omental evisceration in this zone carries a massive hidden risk of a diaphragmatic or hepatic injury. And here's a huge exam pearl for you. Absolutely never do a bedside reduction of an eviscerated omentum. If you do, you risk missing a very serious bowel or diaphragm injury. You want to go with diagnostic laparoscopy because it lets you thoroughly inspect the area and fix any issues right then and there.
Question 41. A 17-year-old male has a stab wound at the left 7th intercostal space. He's vitally stable and his exam is totally normal. Best management. A, local wound exploration. B, thoracotomy. C, diagnostic laparoscopy. D, CT scan abdomen. Or E, exploratory laparotomy. The right answer is C, diagnostic laparoscopy. You see, this specific thoraco-abdominal zone is super tricky because it carries a really high risk for injuries that cross the diaphragm. A standard CT scan might actually completely miss a tiny diaphragmatic tear. Because of that, diagnostic laparoscopy is your absolute gold standard for evaluating the diaphragm in stable patients.
Question 42. Imagine a stab wound in the left 2nd intercostal space. What's the most likely injured structure? A, left atrium, B, left ventricle, C, right atrium, D, right ventricle, or E, SVC? It's A, the left atrium. A penetrating injury right at the left 2nd intercostal space directly threatens the structures at the base of the heart. We're talking the pulmonary trunk, the left pulmonary artery, and the left atrium. And for an essential exam pearl, remember to contrast this with the right 2nd intercostal space, which points over toward the superior vena cava and the ascending aorta. Oh, and don't let the left ventricle option trick you. Anatomically, the left ventricle sits way further down.
Question 43. So what is the most at-risk organ in blunt trauma to the left lower chest? A, liver, B, spleen, C, stomach, D, pancreas, or E, kidney? The answer is B, the spleen. Your left lower ribs, specifically ribs 9, 10, and 11, lie right over the spleen to protect it. So a severe blunt force to that exact area makes the spleen incredibly susceptible. It's actually the most commonly injured solid organ in blunt trauma. A classic must-know exam pearl here is Kier's sign. That's when diaphragmatic irritation from a bleeding spleen causes referred pain all the way up in the left shoulder. Basically, if you see left lower rib fractures, your brain should immediately scream spleen injury.
Question 44. A patient comes in with a stab wound in the right 2nd intercostal space, just medial to the midclavicular line, and they are in shock. What's the cause? A, great vessel injury, B, hemothorax, C, pneumothorax, D, tension pneumothorax, or E, diaphragm rupture. The correct answer is A, great vessel injury. Any penetrating injury inside the anatomical cardiac box brings a crazy high risk of hitting the aorta, SVC, or pulmonary artery. That leads to catastrophic hemorrhage or tamponade. Your exam pearl, a cardiac box injury absolutely mandates an immediate cardiac workup. The fast echo is going to be your best friend here. Also, just keep in mind that the right ventricle is the most commonly injured chamber when we're talking about penetrating anterior chest trauma.
Question 45. A patient develops hypotension, jugular venous distension, and muffled heart sounds right after a road traffic accident. What's your diagnosis? A, tension pneumothorax, B, open pneumothorax, C, massive hemothorax, D, cardiac tamponade, or E, sternum fracture? It's D, cardiac tamponade. This specific presentation is exactly what we call Beck's triad. It's the classic conformation of cardiac tamponade, causing obstructive shock because pericardial blood builds up and physically stops the heart from pumping properly. For test A, remember that pulsus paradoxus might also show up alongside Beck's triad. A quick, fast scan will confirm this incredibly life-threatening diagnosis in seconds.
Question 46. Which of these is the correct clinical statement regarding cardiac tamponade? A, Kussmaul sign in expiration. B, pulsus paradoxus unrelated to respiration. C, Beck's triad includes pulsus paradoxus. Or D, and E, small fluid removal relieves symptoms immediately. The correct choice is D and E. The pericardial sac is extremely volume pressure sensitive. You don't have to drain a massive amount of fluid to literally save the patient's life. Removing just 15 to 20 milliliters can drop that intrapericardial pressure drastically and give you an immediate dramatic clinical improvement. That is exactly why an emergency pericardiacentesis is such a crucial life-saving move.
Question 47. A chest X-ray shows an air fluid level in the left chest, plus you can see an NG tube coiling up in the thorax. What's the next step? A. DPL, B. Laparotomy, C. Thoracotomy, D. Endoscopy, or E. Chest tube. The correct answer is B. Laparotomy. The second you see an NG tube coiling in the chest, it's a dead giveaway for a diaphragmatic rupture. The reason we go with the laparotomy is that an acute diaphragmatic rupture absolutely requires an abdominal approach so you can properly pull down the herniated organs and fix the defect. The big pearl here, acute ruptures get repaired via laparotomy, but chronic, delayed cases usually need a thoracotomy because thick adhesions have already formed.
Question 48. What is the single best diagnostic test for an esophageal perforation? A. CT scan, B. Chest X-ray, C. Water-soluble contrast esophagram, D. FAST, or E. MRI. It's C, a water-soluble contrast esophagram. The logic is totally solid here. A gastrograph swallow will detect a contrast leak in about 90% of cases. Pay attention to this exam pearl. It's super important. Water-soluble contrast is always your first-line choice. You have to avoid barium initially, because if barium leaks into the mediastinum, it causes a severe, nasty chemical mediastinitis. A CT scan might give you indirect hints like air or fluid, but that contrast swallow is what definitively nails down the leak.
Question 49. Which of the following is an absolute indication for esophageal surgery? A. Septic shock, B. Minimal leak, C. Mediastinal containment, D. Endoscopic perforation, or E. Cervical perforation? The answer is A. Septic shock. If your patient is in septic shock, it means there's uncontrolled contamination actively spreading through the mediastinum or pleural cavity. That kind of instability mandates operative intervention right away, no questions asked. The exam pearls remind us that, sure, stable patients with nicely contained leaks can sometimes be managed conservatively, but if they're unstable or in full-blown sepsis, you have to follow strict surgical principles. We're talking aggressive drainage and definitive tissue repair.
Question 50. What is the best management for a delayed esophageal perforation, meaning they presented more than 24 hours after the injury? A. Observation, B. Primary repair, C. Drainage plus feeding jejunostomy, D. Reconstruction, or E. Conservative antibiotics only. It's C. Drainage plus a feeding jejunostomy. When a patient presents this late, severe local inflammation and tissue necrosis have already taken over. Because that tissue is now incredibly friable, the chance of a primary repair actually holding up is practically zero. So your surgical strategy has to completely flip. Early presentations under 24 hours, they get that primary repair. But those late presentations over 24 hours require drainage and diversion, typically using a feeding jejunostomy to make sure the patient still gets vital nutrition while their body heals.
Question 51. You've got a trauma patient presenting with subcutaneous emphysema, pneumomediastinum, and a pneumothorax. Diagnosis? A. Tracheobronchial injury, B. Esophageal injury, C. Aortic rupture, D. Sucking chest wound, or E. Pulmonary contusion. The answer is A. Tracheobronchial injury. When you see this exact constellation of symptoms, it points straight to a massive air leak escaping from the major airways. That's what causes all that extensive mediastinal and cervical emphysema. For the exams, remember, if you place a chest tube and instantly get a massive, continuous air leak that just won't stop, a tracheobronchial injury is your major clue. And bronchoscopy? That's your gold standard to pinpoint the exact location of the tear before going in for a surgical repair.
Question 52. What is the absolute best position for a pregnant trauma patient? A. Prone, B. Supine left lateral, C. Supine right lateral, D. Sitting, or E. Standing. The correct answer is B. Supine left lateral. By positioning the patient with a left lateral tilt, you actively stop the heavy, gravid uterus from compressing the inferior vena cava. This completely avoids supine hypotensive syndrome and drastically improves the mother's venous return. Your critical takeaways for the exam: never ever keep a term pregnant patient fully supine during trauma resuscitation. And remember, simultaneous fetal monitoring isn't optional, it is completely mandatory. So, after running through all these high-yield scenarios, the real question is, are you ready to spot these hidden clinical traps on your actual exam?